Good afternoon, everybody. On behalf of the DVH Center Climate Change, Lakeside Education Trust, and International Pediatric Association of Geneva, I have a great pleasure extending invitation for all of you, the monthly program to attend here. And this is the month for Gastroparesis Awareness Month. We have topic of environmental issues in gastroparesis and preventive measures. In the absence of our chairman, we want extend invitation to J. Srinivasan to formally extend the invitation for the speaker and all of you. Thank you very much. J. Srinivasan, as you know, he's the founder of many of the new people may not be knowing. He's the founder of this institute, and is a man with certain values. He practices what he teaches, and his uncle, none other than Nobel laureate Sir C.V. Raman, and is always helping hand academics and helping people how to learn. And this is something great, and we feel a great pleasure extending invitation for him to come over here, extend a formal invitation for all of you. Thank you. Over to Srinivasan, sir.
So welcome you all to the monthly seminar that's organized with Dr. Paramesh for the last 3 years. We have covered a number of issues ranging from neuro to various other issues. But one issue which is relevant to climate change is related to our digestive system, because as the climate change has occurred over the last 50 years, the number of heavy rainfall events have gone up by 50%. And with our poor infrastructure, our water quality has gone down tremendously. So I'm sure the doctors are seeing a lot of cases related to gastro. And so you'd like to know what is the new development in this field. And I'm very happy that Dr. Palmesh managed to get Dr. Naresh Bhatt to talk about this topic. I wanted to introduce him to the audience.
Thank you, sir. Just highlighting about the subject matter and then introducing the speaker is my duty now. I think gastroparesis is a delayed emptying of the stomach content, which results in nausea, vomiting, bloating of the stomach, and showing the stomach fullness after eating, early satiety, abdominal pain causing significant morbidity. Severe dehydration is a concern during the hot weather with humidity. The factors which contribute to gastroparesis are diabetes number 1 we come across, and viral infection, especially rotavirus, and post-surgical gastrointestinal tract any operations. Drugs like opioids, antidepressant, allergy medicine can also contribute to a certain extent. Autoimmune gastrointestinal dysmotility, and also the idiopathy sometimes will not be. How often you see this problem? Some study shows a 21.5% per 1,000 population. I think it varies in different areas. And to talk this important subject, we have none other than Dr. Naresh Bhatt. He is the Chief of Gastroenterology, Hepatology at Aster CMI Hospital in Bangalore. He did his MBBS in St. John's Medical College, Bangalore. He received 7 gold medals, including Popal Medal as a best outgoing student. He did his MD and a DM in gastroenterology at PGI Chandigarh. He is in practice for over 30 years. He's a pioneer in clinical gastroenterology and advances in endoscopy. And he trains endoscopists in India and also in Asia in advances of imaging. He was the governing council member of the Indian Society of Gastroenterology, president of Indian Society of Gastroenterology in Karnataka 2013 onwards. He is the president of Society Endoscopy 2000 to 2006. He has many scientific papers published in national, international journals, and many oration awards he received. There's a big list there. I know him for the past 30 years. He being the most sought after gastroenterologist in the country, he's a simple man, down to earth human being with compassion for his patient and trustworthy human being. I'm very proud to know him also personally. And his wife is one of the famous neonatologists. His son is a gastroenterologist. I think proud to have him. Naresh, over to you. We'd like to listen to you.
Thank you so much, sir. I mean, it's precisely about 39 years ago when I was standing outside Dr. Paramesh's door, waiting for quite some time to get an audience with the big man. And it was well worth that wait because he was the only person who gave me a break in 1986 and allowed me entry into the Lakeside Hospital as a gastroenterologist. And ever since that time, he has been a mentor. He's been a role model. I've tried to emulate a lot of what he has done. I've fallen short in many areas, especially his sartorial elegance, which I can never match. And that's why I wore a jacket, normally a jacket. But I said, if Dr. Paramesh is here, he will be elegantly dressed in a suit and a tie. Let me at least wear a jacket to, try and come up to his very high standards. And I hold him in high esteem, and he's been a mentor, and I've learned so many things in life, basically how to interact with people and allow everyone to see or have the spotlight. Dr. Paramesh always gave us a lot of independence and allowed us to bloom. And we were about 8 or 10 of us, relatively young. I was just about 30. Many of us have grown out of that institution, and many of them are now leaders across the country. And we all owe it to Dr. Paramesh, and I'm thankful for his invitation this afternoon. I've been watching the fantastic piece of earth that you all have sort of inherited and have the opportunity to be working here. I think I really envy you. We have a lot of concrete in the place that I work, a few trees here and there, but this greenery is unmatched. Okay, coming back to the stomach. All of us know that the stomach is, all of us are aware, and we're quite happy to say, okay, this is the stomach. And as long as I have a nice full meal a couple of times a day, I'm fine. We all earn so that we can have something to eat. That's ultimately the only thing that we're looking for. If that is satisfied, then we start looking for a house, a car, and so on and so forth. If someone feeds us every day, there's no need to work. So the stomach, therefore, is an organ which many of us take for granted and believe that it's just a kind of a bag that we stuff in food, and that sort of is important for our nutrition. Some of us, unfortunately, have to seek help. And when we have this overwhelming feeling of a kind of heat-like thing in the abdomen, and which we call, as in layman's terms, we call it acidity, gas, a fire in the belly, or whatever you want. And that is, some of us have learned to associate this with the stomach. But let me assure you that the stomach goes much beyond that. It's involved in chemical digestion of proteins. It produces a lot of acid. In fact, I have a nice picture where someone has actually collected the acid from the stomach and then left a blade inside overnight and the next morning the whole blade is disappeared. It's capable of digesting that kind of material, but God has been kind that He's given us a good lining there that can prevent auto digestion of our own stomach. Then we have this business about it also being important in mechanical digestion because of the contractions that it does. There's a term called bezos. Now, bezos are basically concretions in the stomach, which can be because of either milk, which remains there undigested for a long period of time. Some people swallow hair, we call it trichobezor. Then we have food material that accumulates, call it a phytobezor, and so on and so forth. So see what happens. Now this, we had a nun who was staying in a convent, and they had 2 lovely fig trees, and that yielded a lot of figs. Fortunately or unfortunately for her, her friends in the convent did not like figs, so she ate a lot of figs herself. And one day she came to me and said, "Doctor, I'm having some pain in my stomach." And when we looked inside, we found that she had a huge ball inside the stomach. So much so that just could remove it, the endoscope. I tried to remove pieces of it, and you can see that's all fig. It contains a lot of fiber. It also contains some kind of astringent substance that slows down the motility of the stomach. And finally, one of my colleagues had to cut open the stomach and remove this. So this is a food disorder due to eating too many figs. You can have it with other things as well. But just to show the importance of the ability of the stomach to get rid of what is inside, what we eat. We eat a whole lot of nonsense, but it is being very forgiving. It doesn't differentiate most of the time. It just grinds everything like a mixie and pushes it out. And see what happens if it is not able to do so. We know about the heart. The heart has got hugely romanticized in medicine and across the world. Everything is heart, and so it's not surprising that the cardiologist is the most important guy in the medical field. Any party, they look around for the cardiologist, not the gastroenterologist, and never the psychiatrist, because we have romanticized the heart is the source of all emotion. All of us know that the heart beats. We have a pacemaker. Just now, Dr. Parmesh was telling me about his friend who's had a pacemaker put in yesterday because he had some problem with the thing. And we know that the heart has an electrical system. There's a pacemaker. It sends electrical impulses, what we call the AV node, and then that spreads across to the muscle, and that leads to a rhythmic beating of the heart. And this rhythm can change depending on the needs. And of course, there can be disease states where the heart doesn't beat properly. Remember, our friend, the stomach, is no less versatile. It's not just a muscle man which just keeps contracting or produces acid. It has got role to do. We don't realize that when we eat, the stomach has to relax to accommodate. Some of you must be in your hospitals, tulping, as they say, 8 idlis. Now, where's the place for 8 idlis in your stomach unless it relaxes to accommodate that, right? So first thing it does, it relaxes and stretches so that it creates place. After that, it contracts and it's like a mixing. It triturates and grinds all the food, and then finally it sends it across. But here we have a barrier which we call the pylorus, which is a sphincter or a muscle. So it keeps it closed. So whatever activity keeps happening, or grinding is related to the stomach, and at some time it allows it to go through. Now the heart has an electrical activity which is much more complex. I mean, the stomach has a much more complex electrical activity than the heart. So we also have a pacemaker here in the heart. This fellow's only job is to relax. This has a pacemaker and it sends signals across the stomach so that it keeps on contracting. And because the other end is closed, here it's closed, so it keeps on contracting, it goes back, so that ultimately the whole thing is pulverized. So we have a lot of contractions that are going around in the stomach, mainly to aid digestion. So these are some of these, electrical activity that I've shown here. So this electrical activity is not independent. It's not just that it does that. It has got external influences from other nerves. It depends on what you eat, what your mood is, and so on and so forth. So we have a pacemaker and we have thing, and if anything can go wrong, actually a lot of things, wherever it can go wrong, something can go wrong. So it can have problems in relaxation. So you say, patient tells you that, no, doctor, I used to eat 8 idlis, now I eat 2 idlis and I feel full. Or I go to a buffet, I take a plate full of biryani. By the time I've eaten 4, I can't eat anymore. Because the stomach part, the upper part of the stomach doesn't relax. Or he says, I eat comfortable afterwards for 4 hours, 5 hours, I feel my stomach is not emptied at all. I keep burping the same thing. Or worse, I eat something and then after 2-3 hours, I have to put my finger in my mouth and bring it out. So all these can occur because of disturbances in the motility of our stomach. The key word is something called the ICC. ICC is not International Cricket Council. Jay Shah has become the unopposed president yesterday, but that is not ICC. To us, ICC is the interstitial cells of Kayal. A very versatile piece of tissue in the stomach, which is a pacemaker, and very complex mechanism that is able to transmit impulses even without direct contact. It can transmit muscles to the muscles and from the muscles to the muscles and so on. And therefore, there's a rhythmic activity that goes on even at rest when you have not eaten. Is something extremely sort of phenomenal. It's almost difficult to ever imagine that something can happen in something that looks so sort of unappetizing, like a bladder or something like that. So any disturbance in this interstitial cells of Kayal is the fundamental basis for changes in the motility of the stomach. Now, so much for the motility of this part, but remember that there is a barrier here. This is called the pyloric sphincter. A sphincter, as you would realize, is basically something that can open or close. And if it remains closed, nothing can go through it. If it relaxes, it allows something to go through, right? So once the stomach feels that, yes, I have ground the whole thing, is ready to go out, then there is this coordinated antropyloric complex which pushes things into the duodenum. So not only do you need this to be functioning well, but this high pressure area to overcome the resistance in this pyloric sphincter. We'll see that this becomes extremely important in the genesis of symptoms and our treatment as well. So the pylorus is there in the distal part of the stomach. It's a kind of a gatekeeper. It coordinates gastric empty, and it has a lot of muscular activity that is controlled by nerves as well as hormones. So it regulates empty. It's a response to food. So it's a dynamic thing. It's not just a door that opens and closes. It's very dynamic. There are certain diseases that affect only this. We have something that I'm sure Dr. Parmesh has diagnosed many of these babies, which you call an idiopathic hypertrophic stenosis in the stomach. The young babies, just about a few weeks old, and they just seem to be vomiting. And a very experienced and intelligent pediatrician like Dr. Parmesh can just put their hands on the stomach and say, I think I can feel that thing in this baby, and just get it operated. And within, say, a day or two, the baby is fine. So these diseases do occur and are important to recognize. Now the next issue is, okay, we eat. What happens when we eat? What happens when we eat, say, eat ragi mudde, or you drink water, or you have something like a sports drink. You have a smoothie. You drink water, you have a ragi mudde. What happens? The time taken to empty is very different. Because liquids, being liquids, they can flow easily across the lower part of the stomach and into the small intestine. Solids need to be triturated and they take time. And these things like smoothies and things like that are somewhere in between. So there is a time period. But if you look in patients, Dr. Parmesh mentioned that diabetes is a very important cause of keratosis. Look, that even after 4 or 5 hours, a lot of it is remaining in the stomach. So what we eat decides how quickly the digestion starts. So gastroparesis, therefore, is a kind of paralysis of the stomach. All of us know paralysis, the hand is paralyzed, the face is paralyzed, and so on. But you never thought that the stomach has got so much nerve and muscle that it can be paralyzed, but it can. And far more often than the paralysis that we see in strokes. So it's a chronic symptomatic disorder of the stomach. So how do we diagnose this? We have to have some symptoms. There should be no obstruction in the sense there should not be a cancer there, or there should not be an ulcer or something that's actually blocking the path. And we should show that there is a delay in gastric emptying. Now, why as environmentalists, why should we ever even be sort of have knowledge about this? Because the most important cause for this is diabetes. And we know that diabetes is largely decided by some of it by genes, but a large of it, what happens in your environment, what you eat, your BMI, your lifestyle, and so on and so forth. And if you look at type 1 diabetes, this is the type of diabetes that we see in young children, right, who require insulin, up to 5%. So that's a very large number. Type 2 diabetes, and if you just count the number of people with diabetes in Malleshwaram alone, and just imagine that 1% of them have gastroparesis, which is severe enough, it's a huge number. It perhaps may exceed the number of patients who have heart attacks and diabetes. This is actually a very large number. But it's not only that, various kind of infections, seemingly, I had a patient 2 weeks back and she said, no, doctor, we had gone to Vietnam 5 months ago, came back as fine. And then, after that, I had some diarrhea, I had a fever. But after that, I've been vomiting every other day for no explicable reason. This is an infection-triggered gastroparesis, not uncommon at all. Right? Of course, you can do it because of medication and surgery and so on and so forth. There are a lot of medicines here, antipsychotics, a lot of anti-diabetic medicines, the big blockbuster drug, semaglutide. Some of you heard of it? Olympics is the name thing. It's made the highest amount of money in pharma industry this year. Thought to be useful for diabetics, but being abused for weight loss. can cause a lot of these problems. Of course, we have drugs like opiates, those who abuse things, or cannabis, all of them can cause problems. In diabetes, it's not just the duration of diabetes. Just the fact that the blood sugar goes up delays gastric emptying. You can have a diabetic who's well controlled, doing well. One day he goes and eats, 4 gulab jamuns, and he comes back home. That alone will send his sugars up and he can start vomiting. Can temporarily cause gastroparesis. Chronic hyperglycemia can also actually reduce the number of these interstitial cells of Kayal and cause decreased motility. So one of the ways that we see these patients are they take their insulin, right? Like I do, I take my insulin and then I eat my food. So what happens? Just can anyone imagine what happens if you have gastroparesis? I take my insulin as an injection. It starts acting within minutes. I eat my food thinking that my blood sugar will go up, but that damn thing is staying in the stomach. So the insulin starts acting, my blood sugar comes down to 50s, 40. My stomach is still full of the food. And 4 hours later, 5 hours later, then my sugar goes up. So at some time, I feel low blood sugar, hypoglycemic, and a few hours later, my sugars have gone up to 300. So these erratic glycemic control, and this, unfortunately, most diabetologists do not recognize this. And so we see these patients because they come with vague kind of symptoms, or they say I have a tummy problem and things. And then we diagnose gastroparesis, address it, and their sugars come under control. So the implications are just not simple things, because this can be life-threatening. A low blood sugar going up to 40, 30 can be life-threatening. In fact, I had a patient, I remember when we were working in Lakeside, there was a gentleman who was being treated for epilepsy for 15 years. 15 years being treated as epilepsy, till we found out that his entire problem was hypoglycemia as a result of this thing. So, it can sort of hide in various forms. How do you make out? How many of you here have had nausea? Show of hands. None of you. How many of you feel bloated? No one? Yeah, some of them. Bloated. Some of you. How many of you feel that you eat some food and it tends to remain in the stomach for a long time? Some of you do. So are they all gastroparesis? Obviously not. So we need to have some way to find out who actually has got gastroparesis. And we have this kind of a score, a symptomatic index, where we have put various kind of parameters. And then we ask a patient, do you have symptoms mild or moderate or severe, very severe, and give it a kind of a number. So a score helps us to find out how severe the problem is. So because it is very difficult otherwise to get an idea as to what is happening inside and whom we have to do what. Now, this is the biggest problem, as I see in gastroparesis, is that many other disorders can have the same symptoms. Psychiatric disorders can have the same symptoms. Eating disorders, anorexia nervosa, stress, anxiety, narcotic bowel syndrome, those who take opiates. A lot of people take opiates, especially in North India. Half the labor class are all taking opiates. In the United States, there's a huge epidemic of people taking opioids. I'm sure some of you have read the story of oxycodone. I think there's a Netflix movie on that as well. So there are many other things that can look. And now we have Bangalore, which is soon turning out to be not only the diabetes capital, but also the cannabis capital. A lot of youngsters are using these recreational drugs or weed. They all can affect this. So, which makes the job of a doctor very, very difficult. how to differentiate from the other and whom do you do. The end result, I must confess, is that gastroparesis is hugely underdiagnosed and not treated. And that is why we have an awareness month, so that, some of you can recognize them in, your relatives and friends and seek attention. And hopefully we try to also educate our own colleagues in medicine so that they are able to understand this disorder. So what do? We do some tests to see if there's any blockage, and then we assess gastric motility. This is what we really do. So the way we address this issue of evaluation is we use something called scintigraphy. We can use breath test, a wireless capsule. We can do like an ECG. We can do an EGG. I'll talk about some of the things. So we have a wide variety of tests that help us study the things, the motility and thing of the stomach. Can anyone tell me why we have so many tests and what does it mean? Anyone? When you have many tests, it means that we don't have the right test. We still don't know which test is perfect. We don't have a perfect test. So that's why we have different. So scintigraphy is basically what we do is we give some radioactive substance sort of labeled with food. In the West, they use an egg with bread and jam. But Indians, like always, we are innovative. We have our own idli and butter kind of combo. So those of you who are vegetarians don't have to feel bad. We have an Indian substitute with idlis that has been sort of validated. And then we give that, and then we obtain scans at 1 minute, 30 minutes, 1 hour, 2 hour, and 4 hours. And we get these pictures, and we're able to quantify how much of that is still in the stomach and how much has gone out. Normally, as we saw in that graph, if you give a solid meal, 60% is retained at the end of 2 hours, and only about 9% is retained at 4 hours. Other by 4 hours, 90% has gone out. So, which means that if anything more than that is retained, it is abnormal. And so when we have grading of severity, which is perhaps not so important for you. Now, there's something called an EGG. You've heard of EEG for the brain. You've heard of ECG for the heart. And we have an EGG for the stomach. And we don't cut up on the stomach and put leads on that and study the electrical activity. We can just put it on the abdominal wall and then study it. And we can get good information. We can do it with their fasting, then we give them something to drink and then see what happens. And we have these various waves which tell us whether it's normal or, it's abnormal. And this is one of the kind of reports. I'm sorry, it doesn't not come out too well here, but the whole thing is synthesized by the computer, and it gives you a readout and says, okay, this guy is normal, this guy is not normal. I'm sorry, my apologies, it's not showing up well on this thing, but it's very easy. Just an eyeballing of the report tells you this is normal or abnormal. So this is something that we do fairly routinely in our hospital. So it helps us study these patients very effectively. We can also put some probes into the stomach and study the pressures, which tells you, whether the pressures are normal or they are low pressures and so on and so forth, which also gives you an idea about the motility of the stomach. We don't do this very often. Then in the West, there are some research centers which actually give you a capsule. And that capsule tells you the motor activity, how long it stays in the stomach, and records the motility of the stomach. It gives you an idea as to what is happening. And if you look at it, it's pretty good, as good almost as a scintigraphy. And there's something called an endoflip, which is a new kid on the block that we can sometimes use to look at the pyloric diameters and how sort of elastic it is. Coming to management, the management is multi-pronged. There are many people involved. You have the gastroenterologists, the psychologists, the biomedical engineers, the radionuclide radiologists, GI nurses, dietitians, surgeons, pharmacists. Everyone has a role to play because it can be a difficult problem to treat. The most important thing is diet. And as you realize, there are some things that go faster and some slower. So what we start is what goes in fast, but also gives some calories. So we try to target some calories, but mainly as sports drinks or smoothies and things like that. And once they are able to do that, then we sort of go further. Because as Dr. Parmesh said, that if you don't feed them, they can get extremely malnourished. And that's a huge problem. I have patients who have lost 40 kgs, 50 kgs without any bariatric surgery, but just because they have this disease. And in diabetes, it can be a real problem to manage the diabetes on one hand and look after the nutrition on the other. The other things we can do is use some things which are called prokinetics, that is drugs that improve the motility of the stomach, help the stomach to contract. There are many drugs, I won't go into these, but suffice it to say that they are good in mild disease. A lot of times they have other side effects. So they help, but unfortunately are not the perfect solution. Then we have something called the pylorus directed therapy. If you recollect, I told you the pylorus was that sphincter at the end of the stomach. And if we can somehow manipulate that, it'll allow things to go down faster. So in those patients who have an abnormality that we can demonstrate at the pylorus, we can try and address it. And what do we do? We can put an endoscope, put a balloon and just stretch it so that it becomes a little bigger, or we can inject botulinum toxin into it. But sometimes we do surgeries as well. And the surgeries basically means either you cut that pylorus muscle or join the stomach to the small intestine so that it goes directly inside. But the most exciting thing has been what we call the G poem. It's not no poetry here. It's actually per-oral endoscopic myotomy. And this is very interesting. We go into the stomach, make a little cut in the mucosa, and actually make a tunnel. Like a spy, a raw agent just goes in a tunnel there. And in the tunnel, we go see the muscle, quietly cut the muscle and slip out and close it. All over, patient is home next day eating. So this is called a gastric poem, and now has emerged as one of the most exciting things for the management of gastroparesis. So this is something that we do here as well, not only for gastroparesis, but for something which we call achalasia cardia as well. Then just like you have pacemakers for the heart, you can put some kind of pacemakers or electric stimulating some kind of devices which we can use to stimulate those gastric ICCs and so on. Or you can try some magnetic or electric neuromodulation, can stimulate the vagus nerve or gastric pacing, so on. Some of these are experimental and reserved or compassionate use for really difficult problems. So basically, to summarize, we evaluate, we give them a dietary intervention, prokinetic drugs, do tests to find out whether the stomach emptying is impaired. If it's empty, then we try something on the pylorus. We dilate the pylorus or do a G-poem. If the emptying is normal, then we don't try this, but we try some drugs, or maybe we may take the help of the psychiatrist to manage these patients, because a lot of them have other neuropsychiatric problems which are giving them symptoms. So to summarize, gastroparesis is a result of possibly many things going wrong, not just one. Often goes unrecognized because most of us, doctors and patients, have this fixation with acid. They think if I put my hand on the stomach, it means there's something to do with acidity. And if it is acidity, I have to take an antacid or some drug like pantoprazole or whatever it is. And then all problems end with that drug. Unfortunately not. There are many, many more diseases. In fact, only about 20% of those diseases get sorted out with those drugs. So our fixation with acid has to go to recognize these problems. There are a lot of common mimics which we have to separate out, which can cause confusion. When it comes to management, I think we need to educate majority of the physician who can decide which patient is likely to benefit, not go and operate and do all kinds of things on a patient. Unfortunately, results can be difficult to predict, and as I said, there's a lot of work to be done, and a multidisciplinary team is required to manage. But a simple message for you and your relatives is keep your diabetes under control. If you keep your sugars under control, a lot of gastroparesis can be preventable. What you can't prevent, but at least these are simple things that one can do to sort of lead a better quality of life. I think I'll just stop here and maybe take on questions if you have.
Thank you, Naresh. Any questions, please?
It's a pretty cerebral kind of talk. Unfortunately, I wish I could have simplified it more, but
Well, anyway, it's a learning experience for us. I never knew ICC. Interstitial cell of Kayal is a pacemaker in the stomach. I think first time I'm hearing myself, I never heard earlier also. And also you corrected very well, and scintigraphy and EGG and G-poem. These are all the new terms for all of us. And also I think diabetes is the number one cause in Bangalore, I say is right. That comes from the air pollution. How does the air pollution come? Less than 0.2 micron, crosses the lungs, which enters the bloodstream. It goes all over the vital organs. It damages the insulin producing. So diabetes, air pollution is related to that. Indirectly, it comes to that one. So that is one thing studies have been shown. And baldness is related to that also. Liver disease, everything is all the vital organs.
I think you should talk about baldness. There are more people willing to, sort of listen to that than about diabetes.
So anyway, thank you very much. How best you could be able to manage the diabetes and all those things. Yes, sir. Any questions?
Yeah. So you mentioned about one test, like you take the scan for 1 hour or 2 hours, 4 hours. That is not very quantitative. What makes that test fail?
I'm sorry, what makes that?
You said there is no, let's say, the gold standard for this disease. So in that case, it's very quantitative, right? So what makes it fail?
No, see, it is, as I said, none of these tests are gold standards. They are close to the indicators. So you have to take the history, then you have to interpret the scintigraphy. It's not that you randomly do a scintigraphy and say, this means this. Because even when we interpret scintigraphy reports, we come across a lot of errors which can make a difference. So it's not certainly gold standard tests. That's why we have many modalities that we look at before we take a decision. And this is arbitrary, based on some data that says that with this diet, most of it should go down. It might happen in 90 people, but under 10 people, it may not. So you're right, it's very arbitrary and certainly not sacrosanct.
Any other questions? So, yes, sir. Please go ahead. Mike.
Acidity and gastroparesis.
Where is the dividing line?
Okay. Now the question is, what is acidity? What acidity means, we can be talking about several disorders. The most common being gastroesophageal reflux, right? So where the cardinal symptom would be heartburn and something going up, which we call regurgitation. That is gastroesophageal reflux disorder. So if someone says I'm vomiting, I'm having a lot of bloating, I can't eat enough, it's certainly not reflux disease. It is certainly not ulcer disease. So those initial symptoms have to be analyzed appropriately. Unfortunately, what happens in a busy practitioner thing, he just has 20 seconds to decide. By the time the patient says, Doctor, howda, he's given an antacid or something, which is absolutely the wrong thing to do. So once you do that, it's what I call the gas. Everyone says gas. Gas maybe is just burping. Or worse, he may just be passing gas from below. But to him, it is gas. There are patients who say, I've got gas problem. And the physician says gas problem is obviously related to gas, because gas is the first part of gastric. A gastric means acid. So if the acid means I have to give something blocks acid, so I write omeprazole. What is the patient trying to tell? Doctor, gas problem is there. Ella vayu, ella joint katkolta ide. I can't move my joints, which is in colloquial thing that is called gas problem, because the concept of vayu, disease of the vayu, which causes arthritis. So I think we need to spend a little more time in understanding these subtle things before we lump them all as one disorder. 40 years, 50 years ago, all GI problems in India were only one. You put your hand here, it was gastric problem. You put your hand down, it was amoebiasis. But now, in these 50 years, we know that there are another 200 diseases that we recognize.
So anyway, thank you very much. They also mentioned the importance of evaluation. Spending little time is most important. I just to quote an example just published 2 days ago from North Karnataka, was my student. This child, about 9-year-old, went to the doctor with stiffness and all these things. And they thought of, the doctor couldn't find any reason why it is and all this. They thought it is fixed like. And he went to story. What had happened? For the 9 days, she's eating the grapes, which has not been washed. They sprayed the endosulfan for those things. So slowly she picked up and all this thing, and they did the blood test. So said, okay. They gave the injection. She was all alive for said, because they spent time instead of doing that test. They say EEG and CT is all the usual thing when conventions like. So cholesterol was very high. They saved her life. They just published the case report. And also he sent an article to me. I wrote like, congratulations, sir, you always spend time, talk to the patient, find these 80% of the time from the history you get it. Stethoscope is only 4%, investigation only 8%. So time is the money. American culture has come and we have to adhere to our culture. So with this type of thing, I am ever grateful for you. With a busy time, he's an administrator also there, medical director. With all these things, he made time come over here and educating us. We are grateful. And a token of appreciation from the here, we give a small memento for you. Sir, you also joined us. Thank you, the IFS officer joined us. So we can all have photographs.